very good evening to everybody, and we're going to do breast conservation surgery case today, so that just to highlight the importance of how breast conservative surgery came about, and how it in fact did displace to some extent, especially in our country. It is still quite early days, but how it has managed to create an alternative to a modified radical matter in the last 3 decades of the 20th century. So let me just share my screen with you. Can you see it?
Yes, ma'am.
Yeah, we can see this.
Okay. Right. So we go ahead, and I'll request Dr. Naresh, who's a fellow in our breast unit, to present the case, and from there on we will take you through the journey of this breast conservation surgery as it happened.
Good evening, everyone. So, coming to the case capsule, a 35-year-old pre-menopausal female presented with a swelling in her right breast for the last 5 months, which was insidious on onset and gradually progressive to present size. There is no pain or nipple discharge associated with the lump. There is no complaint of swelling in the axilla or opposite breast. Her BRCA size is 38p. There is no history of chest pain, cough, hemoptysis, or breathlessness. Her appetite is normal. Bowel and bladder habits are normal. There is no family history of breast disease. On physical examination, general survey is essentially normal. On local examination, inspection of the breast, left breast is normal. The position and symmetry of the right breast is normal. The nipple and areola is normal. On palpation, there is a 3 to 3 centimeter lump is palpable in upper outer quadrant of right breast. The skin is free, but lump is fixed to breast tissue. There is no chest wall fixity of the lump. There is no fixity to the muscle. The skin over the breast is normal. There is no palpable lymph node in the axilla and in the supraclavicular region. Systemic examination is normal. On further investigation, on ultrasound, there is a well-defined lobulated lesion of approximate 3.5 to 3.2 centimeter noted at 12 o'clock position of right breast. The lesion is taller than wider and has speculated margins. The lesion also shows minimal vascularity with few specks of calcification within it and post-acoustic shadow. The right breast is normal. Bilateral axilla, there is no significant node seen. Birates 5.
So, Naresh, what about a mammogram?
Since her age is 35.
So, in a suspicious lump, you should be doing a mammogram also in the ACR, the American College of Radiology, says that if there is a lump that is suspicious, then you're well within your right to do a mammogram, even in a 30-year-old, above the age of 30.
Okay.
Okay, go on.
The ultrasound is with normal. Chest X-ray is normal. The bone scan is normal. A core biopsy was done and is suggestive of invasive rectal carcinoma grade 2. A further IHC was done where it turned out to be a ERPR positive tumor with hepatino negative.
So what is the next plan of management? I'm sure you would have discussed all the options of surgery, and what the patient decided was wide local excision with sentinel lymph node biopsy and proceed to axillary dissection if the sentinel node was positive. And she's a young girl, so obviously in young women you would want to offer her a breast conservative surgery. So let me just take you through this journey of breast conservative therapy, and I must tell you that Naresh has put in all the hard work in putting this PowerPoint presentation together, and he was telling me how much he enjoyed putting this together, because everything that you discover is learning, and you realize that history is very important to consolidate your beliefs, that what you believe today is a result of a lot of hard work that has been put into in the past. And when you actually trace that journey, it is actually very, very interesting. And you must realize that all that we do today was subject to ridicule, subject to rejection. And then came a time when, these various things that we do today came to be accepted in the form that we know today. So when we say breast conservation therapy, what it means is a complete removal of the breast cancer with a lump with a margin of normal tissue around it. And this is invariably followed by radiation therapy. So when I say BCT, it means surgery plus radiation. The T is actually, in emphasizing the fact that radiation is an always accompaniment of a breast conservation therapy. So why are we so keen on doing a breast conservation therapy? And that is to provide a survival which is equivalent to mastectomy. Are we there? Then does breast conservation therapy give you that acceptable rate of local recurrence that you very surely want? Because if that is not the case, then you cannot really compete with a mastectomy. And a cosmetic outcome. How does it restore the body image of a person who undergoes this kind of procedure? So these are the primary goals of breast. If we is a tick on all these three, then we are well within our right to do a breast conservation treatment. So let me just take you through the historical perspective on breast conservation therapy. So this was actually described, but see, this was not the time when prospective randomized control trials were happening to compare a breast conservation with a mastectomy. We were still in this time in 1924 continuing to do a radical mastectomy, but there were people who were talking about breast conservation therapy, and it was first described in 1924 by Sir Geoffrey Keynes, an English surgeon at St. Bartholomew Hospital in London. So what Keynes did was, after surgery or removal of the lump, he used radium seeds as an adjunct to surgery. And he reported a 5-year survival of 77% for women with clinically node negative lymph nodes, and about 36% for those in whom the lymph nodes were clinically enlarged. In 1939, M. Vera Peters, a radiation oncologist in Toronto, began treating patients who had undergone conservative surgery with radiation. So this was all happening, but without the kind of evidence to back it, which would have made it the standard of care. By the 1950s and 60s, there were people who did realize that, trying to subject a small lump, which is a centimeter in size, to a mutilating surgery like mastectomy was really getting to people. And that is why breast conservation surgery became increasingly accepted in clinical practice. And in some institutions, this therapeutic approach did actually become the standard of care without evidence to back it. They did not know whether they did better than the mastectomy or not, but they knew that the patients were a happier lot. In the early 1970s is when the trials started happening, and we all attribute it to Bernard Fisher, when several trials were undertaken in effort to confirm the equivalency of mastectomy with breast conservation therapy. At the time of the initial NSABP report in 1985 by Fisher and Associates, they documented that the five-year equivalence of breast conserving surgery compared with mastectomy was, when they compared it, only 23.9% actually became eligible for who were eligible for breast conservation surgery underwent that procedure. So there was a lot of skepticism. This is what I'm saying, that when you start off a procedure, there will be a lot of skepticism. So there were only 24% of the patients who underwent breast conservation, when there were another 76% who would have actually been eligible for it. In 1990s, the National Institute of Health did bring out this statement when they said that breast conservation treatment is an appropriate method of primary therapy for most women with stage 1 and 2 breast cancer. So this was after the trials had happened, and that is when the NIH consensus statement came through. So if you look at these pictures, this would tell you why people had been thinking so seriously about offering a breast conservation surgery to patients who were eligible for it. So if you look at this picture, let me just show you that pointer. Okay. So you can see this is quite a mutilated kind of a chest wall, where you don't have the breast, you don't have the pectoralis major, the minor. So this is a patient who's undergone a Halsteadian radical mastectomy. And compare it with these images, there is really no comparison. look at this woman who's got an intact breast with a little scar that would disappear on radiation, and another patient who's had a radial scar in the lower half of the breast, and a breast shape is restored completely. Who would not want a result like this if there is no compromise on the oncological outcomes? So, like I told you in the beginning, it is when we talk about breast conservation therapy, we have to be very clear in our minds. Is the survival the same? Is the local recurrence acceptable? Are we able to give the patient a cosmetically viable breast or not? So let's talk about survival to start off with. Of course, the first and primary goal of breast conserving surgery is to achieve survival that is equivalent to mastectomy. So to address this question, 6 randomized prospective trials were, were undertaken between 1972 and 1989, which compared breast conservation surgery with mastectomy. Then there was a 7th one, which was conducted later on by Hezevich, who evaluated hormonal therapy as a secondary outcome. But of course, he did show, managed to demonstrate that there was a significantly higher recurrence rate in mastectomy patients with large tumors wherein radiation was not given as compared to those who had mastectomy with radiation or lumpectomy with radiation. So the 20-year follow-up of most of these trials are available, and they do confirm long-term equivalence. So these are the commonly quoted prospective randomized controlled trials, the NSABP B06, the Milan trials, Milan 1, 2, and 3, addressing various issues. And this is Milan 1, really 701 patients. So all these, look at this, this part of the table, and you will see in terms of local recurrence, breast conservation surgery was not doing badly at all. And in terms of overall survival, there's really nothing to pick and choose. So that is where we landed with breast conservation surgery when compared with mastectomy. So then there was a meta-analysis by the EBCTCG group. It included 3,100 patients from these 7 randomized trials, and they saw that there was no difference in the 10-year survival. As you can see, there is really nothing. Both the graphs are overlapping. And the more recent outcomes have come up with even better, interesting data, really, showing that the survival advantage of BCT is more as compared with mastectomy. But most of these studies that have been looked at is of a retrospective nature. So let us look at the first trial that happened, which was the NSABP B06, initiated in the 1970s by Fisher and his co-workers. It was a randomized controlled trial, prospective randomized controlled trial, with 1,851 women randomized into 3 arms, one arm of total mastectomy, the second arm of lumpectomy alone, and the third arm with lumpectomy and radiation. So the patients enrolled had either stage 1 or 2 breast cancers with tumors that were smaller than 4 centimeters. And all patients who had positive axillary nodes did receive adjuvant chemotherapy. So if you look at this overall cumulative survival at 20-year follow-up of this study, you see that the 47%, it was 47% in women who were treated with mastectomy alone, 46% in women treated with lumpectomy alone, and 46% in those who were treated with lumpectomy followed by radiation. So pretty much similar if you look at the mastectomy and the lumpectomy arm. And the cumulative incidence of death from any cause was 47.7% in women with negative nodes, but definitely higher as expected in women with positive nodes. At 15 years evaluation, independent prognostic determinants of poor survival were identified from the NACBP B06 trial. And these factors included the IBTR, the race of the patient, if the nodal status was positive, the nuclear grade and histological type, and the patient age. So women younger than 40 years and those older than 65 years had a decreased overall survival as compared to those between 40 and 65. And at a 20-year follow-up, the IBTR was 39.2% in those who underwent lumpectomy alone, as compared to a 14.3% in those in whom radiation was added to lumpectomy. But uh, incidentally, there was no significant differences in terms of disease-free survival, distant disease-free survival, and overall survival between the three groups, although this has come to be refuted in the later publications. So let us not forget that Umberto Veronesi has had a huge role in adding to this conviction that breast conservation surgery is as good as a mastectomy. So the Milan trials are accredited to him. And what he did, following a clinical trial in which Halsted mastectomy was compared to the less invasive quadrantectomy, no differences were reported in terms of local recurrence, disease-free survival, or overall survival between the two groups. As a result, Umberto Veronesi was the first to state that radical mastectomy is a completely unnecessary surgery which is mutilating for breast cancer in breast cancer of a size of less than 2 centimeters with no palpable lymph nodes. So I'm a big fan of this gentleman, and if you get a chance, you must see how this pathologist turned surgeon actually turned around on its head the concept of treatment of breast cancer. So this is his statement when he said that some years ago, I proposed during a scientific meeting to compare the traditional mutilating mastectomy with a new conservative surgical approach, the so-called quadrantectomy. At this time, I sensed that the radical Halsted mastectomy was not always necessary. This was not well received by the audience, and they thought I was a crazy physician. So how many times have we accused a lot of people of being a little crazy? But I think it is from that craziness that practice changing procedures happen, and Veronesi definitely did pioneer one such. Veronesi was the first in the world, like I said, to state that breast conservation is as good, especially in smaller tumors. So at the time in 1950, the aim was to give maximum tolerated treatment in the hope of curing disease. But Veronesi developed the new concept of minimum effective treatment. We are doing less, but not compromising on the oncological outcomes. So the first studies of Umberto Veronesi was focused on the treatment of cutaneous melanoma. Don't forget, his pathologist background did come to the fore several times when he was working as a surgeon. So the authors, he verified that clinically uninvolved lymph node dissection should not be performed. I'm sure as a pathologist, he must have seen number of dissections where the lymph nodes were actually not involved, but the patient had been subjected to a lot of lymph nodal removal. So he demonstrated that wide excision is not necessary in the treatment of early melanoma. Earlier, really wide excisions used to be done for melanoma, so that was not required. And in fact, survival was identical to those patients in whom a limited resection was done. A 1 centimeter margin was as good as a 3 centimeter margin. So in 1969, as you know, there were a lot of things happening in tandem. The imaging was getting better, the pathology was getting better, trials had started happening. That is when the new thought process also set into the clinical practice. So in 1969, this is the time when the mammography was being introduced, and mammography was able to detect really small tumors. So breast cancer was now being diagnosed at a much earlier stage. So in 1969, the WHO in Geneva convened a meeting of investigators to evaluate the existing methods of diagnosis and treatment of breast cancer. So on this August panel of experts, Umberto Veronesi was also one of them. So he presented a proposal as to why not start a randomized trial to compare the existing traditional mastectomy with a new conservative approach consisting of wide excision or wide resection, the so-called quadrantectomy, followed by radiotherapy. So there was a lot of discussion back and forth, but surprise, surprise, at the end of it, it was accepted. So that brought about Milan 1, which happened between 1973 and 1980. 701 patients eligible patients who had tumors up to the size of 2 centimeters were randomized to receive, uh, they were randomized to receive either a standard treatment, which is the Halsted mastectomy, or a quadrantectomy plus axillary dissection, plus a post-op radiotherapy, and that is gave rise to the synonym of QUART. So that is the randomization. And in July 1st, on July 1st, 1981, NEJM published the first results of the trial. And what it said was that there was no difference between the two groups as regards local recurrence and survival. Another important finding in the Milan 1 study was that the radiotherapy had no carcinogenic effect. But yes, at that time, the kind of radiation portals that were there was definitely scatter beam radiation to the contralateral breast, which doesn't happen very much today because of the advanced technological advances that have been made in radiation. And then came Milan 2, between 1985 and 1987. Now the eligible patients had infiltrating carcinoma of up to 2.5 centimeters, 705 patients randomized to quadrantectomy with axillary dissection and radiotherapy. And the other one was a tumorectomy with axillary dissection and radiotherapy. So the importance of surgical margins in relation to local recurrence was what the Milan 2 aimed to address. All patients underwent axillary dissection and radiation. In quadrantectomy, you were taking a large margin of 2 to 3 centimeters of normal tissue around the tumor, as well as the tumor overlying, the overlying skin was also taken, as well as the underlying fascia. So it was almost the entire quadrant that was being taken out. But in the tumorectomy group, only a rim around the tumor was excised. After a follow-up of 10 years of overall survival and distant metastasis were not different, but the breast IBTR in the group which was treated only with lumpectomy and radiation was higher. And then came Milan 3, again the same group of same eligibility criteria. QUART was compared to quadrantectomy and axillary dissection, this time without radiotherapy. That is the QUAD, where you did not add radiation. And this, the aim of this trial was to clarify the impact of radiotherapy. Was radiotherapy actually adding to the benefit within the QUAD protocol? Was it adding to what surgery managed to achieve? And the results demonstrated a noticeable difference in the rate of local relapse. In the QUAD group, a higher frequency of local failure was seen, especially in the premenopausal subgroup. But the overall survival did not really differ between the two main arms of the study. So this is what Milan 1 was about, that there was no difference between the two groups. Basically, we were comparing mastectomy to QUART. Milan 2 was looking at the importance of surgical margin width in relation to what happened in terms of local recurrence. And Milan 3 was to clarify the role of radiation when it was added to QUART on local regional control. So if you look at the 20-year follow-up of the first Milan 1 trial comparing BCS with radical mastectomy, 30 women in the group that underwent BCT had a recurrence of tumor in the same breast, whereas 8 women who underwent radical mastectomy also had local recurrence. So the cumulative incidence of these events was 8.8% in the BCT group and 2.3% in the radical mastectomy group. There was no significant difference between the two groups in the rates of contralateral breast carcinomas or distant metastasis or second primary cancers. So essentially, there was some difference in the incidence of the ipsilateral breast cancer recurrence. So these are the local recurrence amongst those who underwent the radical mastectomy. And if you look at the breast conservation overall, you do tend to see a slight increase in the number of recurrences here. After median follow-up of 20 years, the rate of death from all causes was 41.7% in the groups who underwent BCS, and 41.2% in the radical mastectomy group. So there was really no difference here. The death rates in the two groups were 26.1% in the BCS group, and it was 24.3% in the mastectomy group. So now we come to the second goal of breast conservative therapy, and that is to maintain local control within an acceptable rate, which is what is the aim. So tumor recurrence is defined as recurrent tumor at the primary site or within the index quadrant in which the tumor was. And the acceptable rate of a 10-year local recurrence is between 5 to 10%. So that is acceptable. So if you talk about cosmetic outcome, that is the third goal of breast conservation surgery, and that will depend entirely on the volume of tissue that is removed. Of course, the tumor versus the breast size would be a significant consideration, and the location of the tumor will also determine what kind of cosmesis you will be able to give to the patient. Tumors in the medial and inferior quadrant are the ones which are notorious for poor cosmetic outcomes as compared to tumors in the upper outer or the lower outer quadrant tumors, where the amount of breast tissue is so much more and the mobility of the breast in the outer quadrant is much more than you would see in the inner quadrant. So we have been through these indications and contraindications in our last class when we were doing the mastectomy bit, but I'll just go over it because this is very important for all of you. If you were to say what are the absolute contraindications to breast conservation, then pregnancy, in the middle of pregnancy, obviously you cannot subject the patient to radiation, so that is why it is a contraindication. If while at surgery you get persistent positive margins, there is no point in offering breast conservation to that patient. If there is inflammatory breast carcinoma, then don't think about breast conservation at all. And if there is extensive microcalcifications, pleomorphic, malignant-looking microcalcifications on the mammogram, BCS is a no-no. So relative contraindications, some of these were absolute contraindications several years ago. History of collagen vascular disease, multiple tumors have ceased to be a contraindication to breast conservation surgery, even if they belong to different quadrants. So like, yeah, that's what is mentioned here. And if there has been a history of prior radiation to the breast area, but because of the kind of radiation that is given now, re-radiation is a possibility. So that is not a contraindication to breast conservation. And like I said, the breast size to tumor size ratio becomes important. You can't be doing, if there is a 4 centimeter lump in a 32 size breast, then you should not be trying to do a breast conservation upfront at least. You may just consider it after subjecting the patient to a neoadjuvant chemotherapy. So this is a very sweet little checklist for planning of breast conservation surgery. So have a very clear picture in your mind before you embark on breast conservative surgery. Try and understand the extent and location of the tumor. If you're having trouble defining the extent and location, especially in younger women, you can go ahead and do an MRI of the breast, which will help you make that decision. The size of the breast, the density of the breast parenchyma, and the grade of ptosis of the breast is an important consideration these days, especially when you're going to offer your patient oncoplasty. If there are previous breast surgeries, then you need to understand how to address the scars that are left by that previous breast surgery. How much of volume has been lost? How are you going to replace it? Is it going to work or not? That's again something that you must work out before you take up the patient for surgery. Tumor biology, especially when considering neoadjuvant treatment, because now you do understand that triple negative breast cancers, T2 upwards, and also HER2 positive tumors, you would actually be subjecting those patients to a neoadjuvant treatment. And then there is every likelihood that there would be a pathological complete response. So in that case, you must remember to call back the patient after a couple of cycles of chemotherapy, or even before they start chemotherapy, so that a clip can be placed into the tumor so that you don't lose sight of the area that has to be removed when the patient comes to you for surgery. So if there are any contraindications to radiotherapy, so you do get patients who've got interstitial lung disease or who have, um, who are bad asthmatics, poor tolerance to, they are likely to tolerate radiotherapy poorly. So there you may not counsel them for a breast conservation surgery. Age and comorbidities of the patient, family history of the patient can be taken into consideration. But then, even if you are a mutation carrier, you are breast conservation surgery is not a contraindication, and patient preference will override every other thing that you plan for the patient. Because if the patient is not keen on breast conservation surgery, however much you think that it is only a centimeter sized tumor, very amenable to breast conservation, the patient has the right to veto your decision and say that she wants to go ahead with a mastectomy, and that is where you should rest your case. So preoperative planning, there has to be a clinical planning, and there has to be an imaging guided planning. So look at the patient very carefully for all those signs that we would want to, because these are signs of a locally advanced disease, and it is not a good case for doing a breast conservative surgery upfront or even later. Because if it is a large tumor, which is with extensive skin involvement, I don't think you should be offering that patient a breast conservative surgery even after neoadjuvant chemotherapy. So you must warn your patient right at the start that, look, this is the situation today. You've got extensive skin involvement, and it is very likely that all this will disappear after your chemotherapy, but I would not be offering you breast conservative surgery even then. Because you must realize that the trials that all happened for breast conservation surgery was for smaller tumors, T1, T2 tumors. So T4B does not really qualify for breast conservative surgery unless it is a limited T4B disease. Like I said, mammogram again is very, very important. Good quality mammograms with magnification views, because now with digital mammogram there is a lot of you can work around the mammogram. You can see a lot of things with the mammogram, and of course, if your mammographic machine is also equipped with tomosynthesis, that makes it even better, because you can pick up additional lesions just on the mammogram. Ultrasound, again, is a very useful tool which complements a mammogram to assess the extent and size of the tumor. And of course, whatever biopsies that you do should be done under ultrasound guidance. Whatever FNACs of the lymph nodes that you do should be done under ultrasound guidance. So ultrasound is all in all a very good tool. And with high resolution ultrasounds, you're also able to pick up microcalcifications that you're actually seeing on mammogram also. So routine use of MRI is not necessary, but in certain patients, especially the young patients with really dense breasts, it is very, very important to do an MRI, because it will give you additional information. I have been served very well by this problem-solving tool called the MRI, especially in young women. You pick up additional lesions, and surprise, surprise, you pick up contralateral lesions also a number of times. So now let us come to the surgical technique of wide local excision. So quadrantectomy is no longer advocated, because obviously quadrantectomy means that you're removing a large area of the breast, which is not required. And of course, the cosmetic outcome would be so much worse as compared to just a wide local excision. So what are the steps of the surgical technique that you would apply to a wide local excision? The first step is, of course, incision. Every single step is important. Incision, where do you place the incision? That is very important. What kind of incision you're going to make is very important. How do you excise the cancer? Because what you feel and how you go about excising the cancer is very, very important. The margin conflict. I can't even begin to tell you the number of years when we've done a back and forth on what is an actual good margin, that eventually in 2014, 15, this controversy has been relatively laid to rest. Specimen orientation, extremely important, especially in a breast conservative surgery. If you don't orient the specimen, your pathologist really would not know which margin is close, and you would not know where to excise more if you do not orient the specimen. Very, very important. Placing markers after breast conserving surgery, extremely important again. It may not be of value to you, but it is of huge value to the patient because your radiation oncologist will decide on the boost based on those markers that you're going to place in that cavity after excision. Revision of margins, of course, there is always a scope to revise margins, especially for those centers where there is no facility for frozen section. Then it is possible that you may have to actually call back a patient for revision of margins. And if you have the facility for frozen section, then revision of margins can happen on the table, provided you have oriented the specimen well and your pathologist comes back and says, look, your inferior margin is very close or your lateral margin is very close, so you know exactly how much to take and where. And of course, the closure is also very, very important. And I'll just come to each of these steps. So when I say incision, we'll talk about the various incisions that are made. So the incisions have to be made in such a manner that that also is of importance in giving cosmesis to the patient. So you could have an inframammary crease incision or the submammary. You could do a circumareolar incision for a small tumor, which is within 2 or 3 centimeters of the areola. Um, I'm not talking about the oncoplastic techniques, but circumareolar, the round block technique is also a circumareolar approach. And axillary incisions, all these are very, very important. So what you're trying to do with a wide local excision, although we say that for margins, when we say no ink on tumor, when you're trying to remove the tumor, you're essentially trying to go a centimeter away from the tumor because you need to have some gross feel of what you're removing, whether it is invasive or DCIS. So 1 centimeter macroscopic margin will encompass both, whether it is ink on tumor or whether it is a 2 millimeter margin as you would want to do in a DCIS. So earlier on, we used to do a skin excision over every tumor, but that is not mandated anymore. Unless the tumor is very, very close to the skin, you don't have to remove the skin which is overlying the tumor. But if the skin is tethered, because then, you know, if you don't remove the skin, then it is very likely that your anterior margin could end up being very close, but not necessary to excise skin routinely. Until not very long ago, we were also excising the entry point of the biopsy needle. That also does not need to be done anymore. You can completely ignore the entry point of the biopsy needle. So when we're talking of the incision, you're basically talking about how the collagen fibers in the skin are oriented. So these are essentially, these are the Langer's lines, which are circular lines. And later on, the other lines that was proposed by Crassel was the Crassel's lines, which are lines of maximum resting skin tension. It was in a more transverse kind of orientation as compared to the Langer's line, which was more circular. So if scars are placed in the lines of maximum resting skin tension, parallel to the Crasel's line, you'll find that you get the best cosmetic outcomes with least hypertrophy and keloids. So these are the incisions, the upper half of the breast, as you're seeing, you're doing a circumareolar. It is parallel to the areola. And if you're doing a lower part of the breast incision, it is best, radial incisions are the best. So once you have made the incision and you have to raise a little flap, you cannot do a wide excision without raising flaps. So skin and subcutaneous fat are dissected off. So once the skin flaps are elevated, make sure that you elevate it 1 to 2 centimeters beyond the edge of the cancer. And then you move your hand in, you will dip your hand in behind the tumor, your non-dominant hand, and then the breast tissue can be divided beyond the fingertips. So you put in your hand like that, and then you would make the incision beyond it. The line of incision through the breast tissue should be 1 centimeter beyond what is felt. So that is where your fingers come in as a guard, and the breast tissue is divided 1 centimeter deep to the deepest aspect of the tumor. So basically, If you've got a lump like that, do this bit of the dissection, go down, to this bit of the dissection, to that bit of the dissection, and to the inferior bit of the dissection, and then do the deep part of the dissection. And if you feel that it is close to the muscle, you need to take the muscle, you have to do that. So that's what I mean when you place the hand just beyond the tumor. And then you have to grasp it on all sides and then complete the excision. The lower bit of the excision or the deep part of the excision can be completed. So it is usually not, it is usual, but not always necessary to remove full thickness of the breast tissue, because invariably we go down to the muscle these days, especially because when you have to do oncoplasty, you want to move tissue, you have to go down to the muscle. But if it is a small tumor not requiring an oncoplasty, you don't necessarily have to remove not necessarily have to go down to the muscle. You can just remove enough breast tissue in towards the deeper aspect of the tumor. If you've got 1 centimeter of breast tissue deep to the tumor, that's good enough. But if the tumor is infiltrating the pectoralis major, make sure that you remove that affected muscle beneath the tumor as well. So like that's what exactly what I was saying. So here, that's the tumor here. If that's the tumor, you can just get away with taking the breast tissue there. But if the tumor is there and it is almost infiltrating the muscle, then take a piece of muscle also with it. So then I come to the margin conflict. Like I said, that we have lived with this margin conflict for a long time, not really knowing what is an adequate margin. Every conference used to be, full of these questions that what is the actual margin that we're looking at. So it was in the conference held in 2014, and based on a meta-analysis, they found that no income tumor for invasive is good enough, and for DCIS, a 2 millimeter margin is good enough. So what comes through this is that local recurrence is influenced by an interaction of factors and not just one factor. But then let me reiterate here that margin still continues to be an important cog in the wheel and cannot be ignored in getting the optimum outcomes that you desire for your patient. So the standard treatment of a local recurrence after breast conservation surgery is a mastectomy, but that does not mean that you cannot go ahead and do a re-excision, especially if the breast is of a good size. So this is what ink does. So, that's where the ink is. But the thing is, you have to ink the margin, and this ink is used to define the margin surface at various distances from the tumor edge. So if this is the tumor, you will have to talk about this margin and that margin, all which show ink. So that is how you would say, where is the ink from the tumor edge. So to understand more about, the margins, a margin probe was also introduced. And this is the technique of using ultrasound guided incision. You're trying to look at the tumor all the time with the ultrasound probe and trying to aim for a 1 centimeter margin based on what the ultrasound shows you. So this is a very, very interesting paper, which I would urge all of you to read. And he is the man behind the margins, Roland Holland, who started investigating mammograms and their relation to pathological findings, and as a part of the first European pilot of breast screening. And it was what he, came up with, which was used by Umberto Veronesi as key evidence in support of breast conserving surgery. That is how Umberto Veronesi actually embarked on those trials to demonstrate that margins, if you take good margins, then you're well within your right to do a breast conserving surgery. Although Holland did show that there were tumor foci beyond what you were seeing, but whether those tumor foci were of clinical relevance or not is something that we know today probably they are not. So these are the original drawings of tumor distribution in a mastectomy specimen. This is the nipple in the center, the invasive tumor in the upper outer quadrant, and there are foci of DCIS, surrounding the invasive tumor. So you can understand it's quite a largish area around which, besides the primary tumor, there could be areas of DCIS. So this is the same thing that he's trying to represent in a graph, where you can see if that is the tumor, you could have DCIS within 2 centimeters, and in a small percentage, even up to 4 centimeters. Like I told you, specimen orientation is very, very important. You can do it with sutures, you can do it with Liger clips. Liger clips are especially useful if suppose your patient has had neoadjuvant chemotherapy and has now come with complete response to your chemotherapy, and there is a clip there. So how do you get to that point? So then you would put in a wire to localize the clip, and then you would go all around that clip to excise the tumor. And now you have to see whether that wire is reached that area, which may show a small fibrotic area, or there may be a small microcalcification there. That will be picked up by a specimen mammogram. So when you're doing a specimen mammogram of the tumor of the tissue that you've removed, you can orient it with Liger clips because that's radio opaque, and you can see clearly which margin is closed even on a mammogram. So this will give you a good orientation of where you are. So this helps the surgeon to determine if the target lesion has been excised, and also allows to assess the completeness of excision at the radial margins. So this is what a specimen would look like. This is one of our cases only. And we orient it with sutures. This is the orientation suture. And this is how we send it for a specimen mammogram. That is the wire there. That is the residual tumor, which is not palpable. And we have put these clips. So you can put the clips whichever way you want. You can put 1 clip superior, 2 clip medial, 3 clip inferior, and 4 or a crisscross clip on the lateral margins, just so that you get a fairly good idea as to whether you've managed to remove the entire tumor or not. So that's the way it needs to be done. So now revision of margins, because see, breast is not a very, very geometrical kind of an organ where if you were to remove tissue, you would remove it as a sphere. It doesn't happen like that. So these discrepancies will always be there. You could have a margin which is 4 centimeters. You could have another margin which is about a centimeter or 5 millimeters, whichever. So that is why orientation becomes important. It is possible that this margin is actually closed. And what happens if it is closed? So your pathologist says, look, your medial margin is closed. So then I will go ahead and excise that additional margin. I just go and look at the medial margin. I don't go anywhere else. That is because I have oriented the specimen right, and my pathologist has told me exactly which margin to remove. Like I've told you, placing markers after BCS is an absolute mandate. Most young patients and older patients are treated by radiation after BCS, and they will have a local tumor bed boost, and that is where the markers become important. To help facilitate this boost, we place 4 clips, or rather 5 clips, superior, inferior, medial, lateral, and 1 in the center. So this is what is going to help your radiation oncologist do the boost. So now, earlier on, what we used to do is, the surgeons would be very happy. We used to not close the cavity. We used to just approximate the subcutaneous and do a subcuticular stitch on the skin. And the patient used to really look good in the post-op because the seroma would fill up, and the cavity would fill up with seroma, and you would almost feel like you've restored a beautiful shape to the breast. It is only after the patient would go to the radiation oncologist, and then the seroma would disappear and the skin would dip in, leading to an awful cosmetic result. So that is when oncoplasty helped us understand that, we have to obliterate that dead space, and that dead space obliteration will come with oncoplastic parenchymal reconstruction. And once you've done a breast conservative surgery, we would not normally put in a drain. But with extensive oncoplastic surgeries, sometimes you would need to put in a drain because of the amount of tissue you have mobilized into the cavity. That is fine because you're replacing that cavity with tissue. So even if you were to put in a drain, it is not going to make the cavity, make the breast fall into that cavity. So what we do is the deep dermis is approximated with absorbable suture, and then you can use a monofilament subcuticular suture, which is absorbable, to complete your closure. So I'll just go through special scenarios very quickly. So wide local excision of central tumors, it was a contraindication to breast conservative surgeries. But central cancers, if they are closed but not involving the nipple, can be removed by a standard wide excision, preserving the overlying nipple skin. If the lesion is very superficial and there is tethering, inversion, or invasion, then nipple and areolar complex will definitely have to go. So Grissotti is a procedure where it's an advancement flap, which is a very nice flap with which you can actually, excise this whole thing and use this disc on a pedicle, which is deepithelized, and you could actually fill up this cavity. So this is the incision. So those are the two pillars. You can, this bit is mobile. The lateral half, the outer half of the breast, like I say, is more mobile than the medial aspect, and you can actually push this flap with this disc of skin into the space that you've created after removing the nipple areola, and then the closure happens like that. So this is one of my Grissottis. Of course, the breast will sit a little higher than her other opposite breast. And this is another patient, or was it the same patient? They're different patient. So this is 18 months post-op, and it's a pretty good result. You can also make a nipple on this if the patient desires, but most of our patients don't want a nipple reconstruction. So then we come to the impalpable cancers, because of screening or opportunistic screening techniques, or screening is used in a large manner in the West, and a lot of their cancers are impalpable cancers. So then these can be localized prior to surgery using a variety of techniques. You can mark that impalpable cancer if it is seen on ultrasound. You can do a skin marking. You can inject carbon or blue dye or a radioisotope. You can do a guide wire insertion to localize the tumor. You can use an intraoperative ultrasound, a roll, SNOL, I'll come to each of these techniques, and radioactive seed. Guide wire is the gold standard. We regularly use it, especially if you're comfortable with that technique. It's a great technique. And it can be placed under ultrasound. It can be done under stereotactic guidance, which is on a mammogram table, especially for microcalcifications, which are not visible on ultrasound. You don't have an option but to use the stereotactic table, or even under MRI control. If there are certain lesions which are not visible on ultrasound or stereotactically, but may be visible on MRI, but this is not a very commonly used technique. Most often, ultrasound guidance is what is used. About 95% of tumors are visible on ultrasound. So a lot of times, even if you don't see anything on ultrasound, get an MRI done, and a second look ultrasound will be able to localize that lesion for you. So the advantage of the guide wire is that the distance of the wire from the tumor can be confirmed easily by mammogram, unless if the tumor is not seen on mammogram. And in large area, if there is a large area of microcalcification, then you can use 2 or 3 wires to bracket that whole lesion and plan your incision within the breast around it. So this is the specimen X-ray of a small cancer. That's a little tiny cancer, and the clips have been placed. So the disadvantage, of course, is patient discomfort. Sometimes the wire can get displaced, especially if somebody does not have a lot of experience in doing it, can migrate, and it has to be fixed properly after you have. If it engages with the tumor, it is fine. Then it will not go anywhere. But if it is not engaged with the tumor and it is within the breast tissue, dislodgement is a possible risk. So when you do, when you're doing it under ultrasound guidance, you can place the wire as you can take the shortest route to the lesion. But if you're doing it under stereotactic localization, it will always be done in a CC view, meaning there is a compression from the top and the plate is below. So you'll have to invariably go from the top, even if your tumor is lying in the lower half of the breast. So when that is the case, it is my advice to you to ask your radiologist to to localize the tip of the wire on ultrasound and mark, scratch the surface of the skin, or probably put an ink mark on the closest route to the tumor. Otherwise, if you were to start chasing the wire, you will make the incision here and make a huge tunnel into the lower half of the breast. It is really not desirable. So the best thing to do is ask your radiologist to mark the shortest route to the tumor and deliver the wire into the wound once you see the wire in close to the tumor. So that is how you would, rest of the principles remain the same. But make sure when you're using, trying to do this early on in life, don't use a cautery, because the cautery can really bump off your wire and you can lose the wire completely. So try and do sharp dissection and get the wire and the tumor out with margins. So this is one of our cases where there is a faint, you know, residual with the clip in the middle of that residual tumor, and we have got good margins all around it. This was wire localized by our interventional radiologist. Intraoperative ultrasound localization is not something that we use, but it is a good technique in the sense there is no radioactive, no extra breast punctures. All the margins can be evaluated on table. This can facilitate excision of palpable tumors also, so that you get uniform margins all around. It is very challenging to detect a small lesion, especially if it is a dense breast. And if you use an ultrasound, it can be of great help in removing that lump. So that is how it is done. You have marked the area that needs to be removed on the basis of an ultrasound guidance. And once the tumor is out, ex vivo, you can see whether the tumor has been removed with adequate margins. So role is the use of radioisotope. Role has been used to, where you do is a radio-guided occult lesion localization. You inject radioisotope into the lesion. And if you want to do a sentinel node biopsy along with it, you can use two different isotopes. But then there is another technique, which is the SNOL, where you can do a sentinel node biopsy and the occult lesion localization in the same go. So this is the sentinel node added to role is what is a SNOL. So you can do it in the same surgical session. And we don't use this technique also frequently because we are more comfortable with the wire localization technique. Radioactive seed has also been used, which is the I-125 radioactive seeds. Again, this can be readily evaluated by post-placement confirmation mammograms. So this is the radioactive seed that you see, and this can be easily seen on mammogram. So the other localization methods, they can easily be done. So I would encourage you to try these techniques if you really wish to do that for localization purposes, and that is to inject carbon. So it becomes very easy to identify it when you look for it, when you're excising it. Then superparamagnetic iron oxide, again, for impalpable tumors, has been done with a handheld magnetometer. It is called the CentiMag. But then, so here, you don't have the problem of sentinel node localization and, isotope and a nuclear medicine department and all that. But then it apparently leaves a brownish stain on the skin, which does not go away for a long time. And of course, you need that equipment also, a magnetometer, to identify the tumor. So one must also understand that there is no contraindication to doing a breast conservation surgery after neoadjuvant therapy. So if the size of the tumor is large, you can downsize it with chemotherapy and allow for breast conservation along with an oncoplastic surgery if that is required. So, so that is where chemotherapy can play a role. And this is especially true for large tumors, T3 tumors, which can be downsized and they can be offered breast conservation. Not so much for large T4B lesions. But one must be careful about patient selection. And one must realize that breast conservation surgery after neoadjuvant therapy may have a slightly higher rate of local recurrence as compared to those in whom breast conservation surgery is done upfront. Because the response to neoadjuvant chemotherapy can be very variable. You can have a concentric shrinking if that's the best thing that you would want, that it shrinks concentrically. Complete response, this is a partial response, but it is shrunk concentrically. So then I have to take margins around this concentrically shrunken tumor and not address the original margins. But if the tumor were to break up into pieces like that, then I am not happy offering this patient a breast conservative surgery. So here, the value of MRI does come to the fore. So pre-neoadjuvant chemotherapy MRI And the post-neoadjuvant chemotherapy MRI will tell you exactly how the tumor has shrunken and allow you to make a good decision for your patients. So I've already told you, so once you have put the patient on neoadjuvant chemotherapy, the decision is to go ahead with neoadjuvant, don't forget to place a clip. Because what would you do in a situation like this where the tumor has completely disappeared if you did not place a clip? And even a radioactive seed can be placed instead of a simple metal clip, because this radioactive seed can remain alive for about 3 months. And if that 3 to 4 months, so based on that, you should place the seed accordingly, depending on when you're finishing the neoadjuvant, and you can take up the patient for surgery. So like I said, MRI is the most accurate method. But then in those centers where MRI is not available, breast ultrasound can also be useful. The post-operative complications are pretty much similar: bleeding with hematoma formation, infection, incomplete excision because of lack of control on the margins because you don't have a frozen. Poor cosmetic results can also happen, especially if if your mobilization has been such that there is fat necrosis, or if you've not been able to fill up the cavity and the radiation has happened, so you can have a poor cosmetic result. So incomplete excision rates can vary between 50 and 40%. In fact, it is slightly higher than this in various settings. It can range anywhere between 20 to 60%. And this is when we're saying incomplete excision, it essentially means that there is an involved margin. And most of the centers in the West do not employ frozen section for margins. They're happy to bring back their patients for re-excision. So that is how high it is, which I would say is not acceptable in our practice. We regularly use frozen section, and our re-excision rates are close to nil. Whatever re-excision we would do would be on the operating table, because our pathologist will tell us exactly which margin needs to be revised on table if there is any. So what are the factors which result in poor cosmetic outcome? Large breasts, especially the fatty breasts, a large tumor size, central tumor location, if it is a very ptotic breast, increased volume of breast tissue that is removed if you do more than 20 to 30% without oncoplasty. If it is a re-excision procedure, you've excised once and you're doing another re-excision, you will invariably land up with a poor cosmetic outcome if you don't do a good oncoplasty with it. If the scar length were to increase, and if there are any other, post-operative complications, there is infection, it will lead to a poor cosmetic result. If you do an axillary dissection, again, can lead to poor cosmetic outcomes, especially if there is edema of the breast, which happens because of the axillary dissection. Increasing dose of radiotherapy, especially because of a boost. There could be desquamation, there could be hyperpigmentation, there could be hardening and edema of the skin, which doesn't go away after radiotherapy. All that can contribute to poor cosmetic outcome. And even chemotherapy at times can lead to poor cosmetic outcome. So when you do an excision of the specimen, you must actually weigh that specimen also to understand how much volume you have to replace. And also critical is the percentage, because this is what we commonly use as the method by which we decide how much of volume has to be replaced and what kind of oncoplasty needs to happen. Because if the excisions are more than 10%, 10 to 20%, poor cosmetic results go up by 50%. So when more than 10% or 20% of breast volume is excised, you will need to reshape the breast with volume replacement using local flaps or lipofilling or any other oncoplastic procedure. So re-excision for, like I said, if there are unknown margins, a lot of times we do get patients who've had a lumpectomy outside and there is no mention about the margins on pathology, then you must take up that patient for re-excision. So that is the point where we do re-excise. Or if there is positive margins and on ink, on pathology review, then you must go ahead and re-excise. So re-excision is reported as necessary in 20 to 30% of breast conserving surgeries. Thank you. So that's it from me, and it's been a pretty long lecture, but I hope you enjoyed it. Let me just get rid of this point.
It's a wonderful lecture as usual, Dr. Geeta. And
Thank you.
yeah, and any questions, Dr. Naresh? You have any questions or comments, please? There's a question or two in the chat box, Dr. Geeta. If you can just
Yeah,
open the
I will
chat.
have a look. Yeah.
Dr. Geeta, I have a question.
So what is limited T4B disease? So, when I say limited T4B disease, you could have a tumor which has got localized PDO. If it is localized PD orange, it is not extensive PD orange. That would be a limited T4B, which essentially is a term that we use when we want to consider a patient for breast conservation surgery. So I've already told you how to plan for BCS in even in T4B breast cancers. That is the way we would treat it. Here, there is no direct infiltration of the skin. There is just localized PDO. There, you can leave a clip as we would, and possibly even take out a bit of skin if you think that there is something to remove at that point of time. If the skin has completely resolved on chemotherapy, you don't need to that. If skin involved, BCS should not be done. Then what's the part of skin removal you explained during BCS incision? So if skin is involved, when I say skin is involved, no BCS, that is when there is extensive edema of the breast. That is when you should not contemplate BCS. But if, even in a primary setting, skin tethering does not change your stage. But if there is skin tethering, I would remove an ellipse of skin on top of the tumor. So that is, but I would still be offering breast conservative surgery. Skin tethering is not a contraindication to breast conservative surgery. But the thing is, when you're doing an oncoplasty, you will still have to remember that you are going to remove that piece of skin on top of the tumor. So where exactly clips are placed, like I've told you, you have to place the skin in the center. If you're doing it in the neoadjuvant chemotherapy setting, so your interventional radiologist will place the clip in the center of the tumor. So why we say after 2 cycles? Because then you know exactly how the tumor is shrinking. If it is shrinking concentrically into the center, then you place the clip after 2 cycles. But I'm a little worried about triple negatives and HER2 positive because they tend to respond beautifully even after a couple of cycles of chemotherapy. So in those situations, you may consider putting in the clip right at the beginning rather than after 2 cycles. If skin is tethered at baseline, there is complete, should we still consider? So again, you will have to follow, you have to see how it is. If the skin has responded, there is no tethering that you see after neoadjuvant chemotherapy, you can keep the skin. There is no need to remove that skin. Okay.
Ma'am, I have a question.
Yes.
When you ask the patient to undergo radiotherapy after BCS, is it after completion chemotherapy if at all the patient is having anterior chemotherapy, or you defer the completion chemotherapy and you give radiotherapy followed by chemotherapy?
No. So the sequence of things would be, you would do chemotherapy first, and then assess the patient. After 4 cycles of chemotherapy, the patient should come back to you. So you have to have a good relationship with your medical oncologist to ensure that the patient comes back to you. Lots of time we don't see them at all, so we see them much later. But it is a good idea to see after 4 cycles, and then see if there is regression. If you see good regression, continue chemotherapy. That is the dictum that I follow and most of us follow. Continue chemotherapy, finish chemotherapy, and then go ahead with surgery, followed by radiation. And if you want to do a sandwich, you can. Suppose you think that the tumor is not responding, or it is just stable and just not going anywhere, and you want to intervene earlier, that may be a good idea. So go ahead, excise the tumor. If you can do a breast conservation, do it then. If you can't, tell the patient, look, you're not responding. In fact, you've grown a little since the last time, after the last 4 chemotherapies. Go ahead and do a mastectomy. Do the remaining chemotherapy. Radiation will always follow chemotherapy. But see, if your patient is on targeted treatment, things are different. Because targeted treatment continues to happen irrespective of whatever is happening. Whether it is surgery, a patient can have targeted treatment a day after your surgery also. So we are not interrupting the targeted treatment, but chemotherapy, we would like to finish it in one go. And if you're interrupting chemotherapy and doing surgery in between, it has to be chemotherapy, surgery, chemotherapy, followed by radiotherapy, and not radiotherapy followed by chemotherapy.
Okay, thank you, ma'am.
Thank you. Any other questions?
Hi, Geeta.
Hi, Selvi.
Sorry, I missed the early part.
Oh, you are the master, man. How do you miss it? I'm sure you know it all.
Good to see you.
Yeah, so this is all the hard work of Naresh, but I think Dr. Naresh is a fellow in our unit. And I think it's a great way to learn, because I think he was so excited at the end of it all. He thought, oh God, what a world of information out there, and he's enjoyed digging into it, and he's brought this to us. And I have just presented to you what Naresh has collected, but what I am happy about is that he has managed to pick up all the nuances of what breast conservative surgery is about, which is a great way to learn. And I would urge all the participants to, dig deep. It's really interesting. There is so much to learn, and information is so easy to get these days. It's not like us, we were at the mercy of the photocopier at National Medical Library in Ames, next to Ames. So the photocopier would say, okay, you come back after a week. You go back after trudging in buses and going there and asking him, have you got my photocopied papers? He said, sorry, my photocopier machine went conged off. So you come next week. So we used to be doing that. And look at you guys. Yeah, you've got everything at the push of a button. So I think you're in a great space. It's a great learning space. That's what I realize, and I keep learning every day from you people. So I think it's a great experience. Okay, so there is one little question there. How many clips should be placed post BCS? So what I do is one in the center, superior, inferior, medial, and lateral. So 5 clips. So how do you do it, Selvi?
So again, I put one in the base and then on all the other margins. So one each, superior, inferior. Sometimes in a fatty tissue, you don't have enough purchase and the clips might fall off. So when you take a stitch, you realize that your clip is come off. So those things happen. But generally, it's good to have at least a few clips, basically to tell the radiation oncologist where the original tumor was, because we do now a lot of shifting, and your incisions are not in the same place as where the tumor bed is likely to be. So you tunnel and you make those excisions with all these oncoplastic techniques. So it is imperative that we have at least a few clips there to show where the tumor bed was for the radiation oncologist to give a boost.
So what we also do is, our radiation oncologist would do a pre-op planning CT. So that, she knows, she has a footprint, she knows that this was where the original tumor was.
So this pre-operative planning CT, if they have a PET CT in your same institution, can they use the same images, or do they have to do a specific?
So what they do is they do it on their machine. So this planning CT thing is done on their machine and they store it.
Yeah.
Because their machine is equipped with a CT planner also. So that is how they do it. So
if they've done it in another machine, they cannot use the same.
They can import it. They can import it. Yeah, that's possible.
Yeah, it makes sense. You have a roadmap to what it was before and then after treatment.
And they do it in the same position as the treatment position. So that makes it more accurate. Okay, thank you so much.
Thanks, Dr. Geeta.
Thank you.
For taking so much time.
For the opportunity. Thank you. Bye-bye.
Thank you, Naresh.
Thanks,
Thank
Naresh.
you, madam.
Bye.
We'll see you again coming Tuesday.
Okay, let's think what we'll do next time.